Hello everyone and welcome to Edusurg Clinics. I am Dr. Gunjan Desai and today we are going to continue our discussion on ethics and code of conduct. And in this part of the series, we are going to discuss a lot on consent in clinical practice. And a very important part of consent is that it has to be an informed consent. So we are going to see what is informed and why this is a very important topic from medical, moral, ethical, as well as legal point of view. So we have already seen the why of moral principles, the ethics that provide direction to action. And in this part, we are going to see how to apply these principles into practice. The code of professional conduct as per the American Medical Association, you can have a look at that page as well. And we are going to emphasize on how to take consent, and a very important line that you need to take home is that consent is a communication, it is not a signature. So, if there is one line that you want to take from this presentation, it is that you have to understand the communication process of consent and not only a signature. So, when we say code of conduct, what that means is it means that you have to uphold the values and morals that you saw in the previous presentation in medical practice, and this will help us in building an ethical, safe, and fair healthcare which is guided by laws. And the legal framework of this, as well as the consent, we will see in upcoming presentation. So, in code of conduct, when you want to apply ethics into practice, there are some important points that have been highlighted. The most important point is consent, where the basis is honesty, truthfulness, and collaborative decision making. What that means is that as doctor, you alone are not supposed to make the decision. You have to inform the patient of all the various permutations and combinations that are possible. And based on that information, the two of you, the doctor and the patient, the relatives together make a decision, which is known as collaborative decision making. Another important point in professional code of conduct is accountability. That is, you have to be answerable to patients, peers, as well as society. Integrity, what that means is that don't make false claims. We see a lot of doctors promoting their patients on social media, something that is not ethical. You cannot do financial exploitation of the patient or indulge in malpractices. Competence, maintain updated medical knowledge. It is something that most of us do by doing CMEs, taking lectures like this, discussing topics is also a way of updating medical knowledge. And confidentiality, like I said, you can't disclose photos of your patients in social media. That is something that is a breach of confidentiality. Any identifiable mark on a photograph needs to be covered, and a consent of the patient needs to be taken before putting it on social media. Remember that even with consent, you cannot make a video and put it on Facebook and say that my patient's giving a feedback with consent. That is not allowed. Okay. So you have to protect the patient's private information, and this has to be divulged only when legally necessary. So, like I said, there is a legal framework that manages all these principles. For India, National Medical Commission Code of Ethics is the regulatory body. The BNS and IPC provisions for professional negligence, misconduct, and confidentiality breaches are the laws that are there for practicing consent and ethics. If we look at the international codes, the age-old Hippocratic Oath still holds true, the Geneva Declaration and the American Medical Association Code of Conduct. However, when there are practical scenarios like we saw during the COVID pandemic, there were instances where you had to break confidentiality. End of life issues are still in a gray area and the laws are not very clear on it. So, vested interest can be monetary, can be relation based, can be ethical, can be company related. All these interests have to be kept out of your practice as far as possible. So confidentiality, end of life issues, conflict of interest, like I said, and supporting vested interest. Some of the practical scenarios where the laws are still gray and where the ethical and moral values come into play. So now coming to consent and a stepwise approach to consent. Remember that consent is a process by which a patient voluntarily agrees to a medical intervention after being fully informed. Consent is a process by which a patient voluntarily agrees, very important word, to a medical intervention after being fully informed. Again, very important word. Like I said, this is the most important line of this presentation. Consent is not just a signature, it is a communication process. So the first step is disclosure. That is, you have to give the patient information about diagnosis, procedure, risk, benefits, and alternatives. So all this has to be discussed with the patient. Then you have to assess whether the patient has understood it or not. So the patient must understand information using simple language, that is comprehension. Then understand that yes or no from the patient has to be voluntary. The patient can't be manipulated or coerced to make a decision. There should not be any undue influence. The patient must have capacity to make decision. If it's a 5-year-old patient, of course, we don't take consent from pediatric age group. If it's a patient with short-term memory loss, you can't take a consent. So decisions like these, competence is something that needs to be assessed. So comprehension and competence you need to assess and then allow the patient to make voluntary decision. And then comes the actual documentation where you can have written or oral depending on procedure and explicit agreement between the patient and the treating doctor, and that is what is a consent. So this is an entire communication process where you say something, the patient understands, gives a voluntary consent, and then comes the documentation. Remember that it should be done in a calm and quiet place, not in the hospital lobby. Preferably bedside or outpatients department is actually the best place where you can discuss the entire details that are there in the disclosure. The surgeon, the lead surgeon or the second in line should actually do the consent part and not the junior most person in the team. If you are training the junior most person in the team, you have to be there when the consent is explained. Complement the understanding of the patient and then take the signature. Remember that documentation is very important when it comes to the legal framework. It can be a video documentation that is routinely done in cases of liver transplantations. Paper consent. You can have a procedure specific consent, which is the NABH norm in today's time that you should have a procedure specific consent. SNDT, sign, name, date, and time. That is very important in any document in a hospital. So all these steps are important when you are going to take an informed consent. Now, some common challenging scenarios. Remember, in emergency surgery, it's a trauma patient where the patient is unconscious and no relatives are present. This is a scenario where you may not have a time to obtain consent. Doctrine to necessity, beneficence, you can proceed with treatment and save the life. If the patient is an illiterate patient, remember that any illiterate patient still understands language. So you have to ensure that the patient has understood. You can have an interpreter if needed and a witness and then take a consent. If it's a minor requiring surgery, you have to look at the children's assent, something that is seen more in outside India. Parents and guardians provide consent when it comes to Indian scenario. So autonomy here is very important to consider if you are doing a surgery in a competent child, even though it's a 12-year-old patient. Mentally ill patient, then there is a mental health act and you have to follow the criteria of that act and then take consent from guardian or the appointed representative. Family wants to withhold information. This is a very gray area, truth telling versus family wishes. Ethically, it is very important that you inform the patient, but if it causes a serious harm to the patient, then you may not disclose. Okay. Abortion in married women, as per the MTP Act, only the women's consent is required. So that is something that you need to remember. Vulnerable population in clinical trials, you must ensure voluntary consent and there has to be an ethics committee oversight. and audiovisual recording as per ICMR guidelines. So these are some of the scenarios where you are commonly asked what to do about consent. We have put an ethical challenge that arises in the scenario and the legal ethical consideration. So a slide that may be very useful when you come across these scenarios in practice. Now, types of consent, remember that there can be an implied consent, like a patient coming to your OPD, then you are examining the patient, temperature, pulse, respiratory rate, blood pressure. That is an implied consent that the patient is giving you. Express consent, you ask the patient, may I examine you? The patient says yes, that's a verbal consent, or you take a written consent. Informed consent is what we already saw. And proxy consent, like I said, minor patient, unconscious patient, and mentally unwell or an incapacitated patient. These are the patients who need proxy consent. So these are some of the types of consent that you see. Remember that consent is a legal requirement and an ethical duty, and it protects doctors from legal liability as well as patients from harm. So a sample consent of what we usually take, this is a procedure specific consent, starts with a patient sticker, surgeon's name, diagnosis, procedure, approach is open. So you discuss everything, anesthesia, then what all complications are possible in the surgery, whether a blood transfusion is required, what are the post-operative problems? And remember that all this is discussed in the outpatient department in our OPD before this consent is signed. Then you can have post-operative period, what all problems and what all treatment may be required. We have put ICU stay, transfusion, ventilatory support, extensive investigations, consultation from multi-faculty specialists. So once all this has been discussed, it is told to the patient that you understand the implication, risk, the expenses and the prognosis, and then take a signature. In case a surgery is very complicated, we also put a detailed plan, like a cystoscopy will be required, then laparotomy, then what are the alternatives that have been explained, like small bowel resection, colon divergent stoma, bladder repair, wound open, vac dressing. So all these things have to be discussed. Patient may need one more surgery for wound closure if that is in the plan. If it's a complex surgery, like say pancreatic necrosectomy, then we also mention a line that the patient can have an unfortunate fatality in spite of a prolonged and expensive treatment. In these cases, we also provide an expected expense of the surgical procedure in the patient preferred class and in the hospital. And you also have to say that similar treatments available in other hospitals at a lesser expense. So this is something that based on the scenario that your patient presents with, you take a consent. Okay. So a basic consent which is procedure specific, you add a detailed surgery plan where required. You give a detailed estimate along with a high risk consent when it is required. So some legal rulings that have happened in the field of consent. Remember that the informed consent concept came after the Samira Kohli versus Prabha Manchanda case, where patient consented for diagnostic laparoscopy, but surgeon performed hysterectomy without consent. And this was a Supreme Court ruling that consent for one procedure does not imply consent for another. Another case where doctors refuse emergency care without consent, which is not actually the law. The law is that beneficence takes precedence over consent, and this is where the Supreme Court ruling was that saving life takes priority even without consent in emergencies. Euthanasia and withdrawal of life support, our government does not permit active euthanasia, passive euthanasia is permitted. This highlights autonomy and best interest. HIV positive patients confidentiality versus fiance's right to know, balance between privacy and non-maleficence, because you would harm the fiancée if you don't tell her. So this is something where confidentiality may be breached in matters of public health safety. Another case where there was a request for abortion beyond legal gestational limit due to fetal abnormality, the court emphasized adherence to MTP Act, the Women Patients Autonomy and safety. So these are some of the important cases. If you are interested in medico-legal aspect of our field, then you can go through these discussions as well. So to summarize the series so far, we have seen the four pillars of ethics: the autonomy, beneficence, non-maleficence, and justice. I also add trust, honesty, and truthfulness to it. Once you add applying ethics into practice, code of professional conduct, and competency-based practice. Remember that informed consent is a communication. There are 5 steps: disclosure, comprehension, competence, voluntary, and actual documentation of the procedure. Very important, and a point that cannot be highlighted more, that you have to remember legal aspects: NMC, BNC, AMA, and document. Unless you document your consent, it is not valid in the court. So in the next part of this series, and actually the final part of medical ethics, we will look at some decision making scenarios. We are going to discuss the ethical issues in that movie as well, and what is the legal ruling. And it's a very interesting video because a lot of actual scenarios are going to be discussed. So do tune in for that last discussion on this series on medical ethics and consent. Thank you.